The TB capital, accounting for almost 26% of global incidence, and RNTCP was revised in 2016 with daily ATT regime leading to making patients more prone for developing ethambutol optic neuropathy. Ethambutol is the first-line ATT drug with potential hepatic and ocular side effects. It acts as a chelating agent which disrupts one of the several metal-containing enzyme system leading to ethambutol neuropathy. It is dose and duration dependent, and its incidence widely varies from 1 to 18%. It is partially reversible in initial stages and become irreversible later on. Ethambutol toxicity typically presents between 3 to 5 months, and it presents as bilateral subacute painless loss of central vision, and the fading of colors is the earliest sign. In 13 to 15% cases, patients are asymptomatic but have subclinical toxicity as assessed on VEP and OCT. It is of two types, axial neuritis and periaxial. Axial neuritis is the most common type, leading to visual loss, color vision impairment, and the secocentral scotoma because it affects the papillomacular fibers. Fundus examination may be normal in initial stages, but later on it can become hyperemic, disc edema, disc pallor, and optic atrophy in the later stages. EON, our experience. Over a period of 1 year, 100 patients were referred from CTB department for ophthalmic evaluation. Only 18 patients were diagnosed with ethambutol optic neuropathy, out of which 12 were male and 6 were females, with a male to female ratio of 2:1. A prospective randomized comparative trial was conducted, and the age group was from 17 to 75 years. Incidence of EON was 18% in our study. The average dose of given ethambutol was 800 milligram per day, and the most common type of TB was pulmonary TB, followed by spinal and genital. The most common presenting feature of EON was bilateral diminution of vision, followed by abnormal color vision in 11% cases. 14 patients were having defective color vision in red-green spectrum. Fundus and disc abnormality was present in 70% cases. It was normal in 30% cases, hyperemic disc in 15%, temporal disc pallor in 30%, and 25% cases were already having optic atrophy. Variable fundus presentation in EON, as you can see, the first picture is the normal fundus picture. In the other, there is disc edema, hyperemic disc. The third picture, all these pictures are of one patient. Then the patient progressed to the temporal disc pallor and ultimately optic atrophy over a period of 2 years. Visual field analysis was done in every case, and the abnormality was seen in 50% cases. The most common abnormality was central or secocentral scotoma in 89% cases, while in one patient there was bitemporal visual field defects. 90% cases OCT changes were seen. Increased RNF and GCL thickness was seen in 17% cases. However, thinning was seen in 72% cases. These are the OCT picture. In first picture, there is hyperemic disc with disc edema, which is showing increased RNFL thickness, while in the second picture, it is temporal disc pallor leading to RNFL thinning. The factors which were positively correlated with EON was the duration and dose of ethambutol, advanced age, hypertension, chronic smoking, and the renal dysfunction. So we have given trial of levodopa in our patients, as there is no safe dose of ethambutol and no definitive treatment. Why we give levodopa? Because there is established role of levodopa in recent onset NAION. With this background, we conducted a trial of levodopa in established cases of EON after taking clearance from the Institutional Ethics Committee. Total 18 cases were included, which were divided equally into two groups, cases and controls. 100 milligram levodopa TDS for 6 weeks was given, along with the zinc and vitamin supplements after ruling out the contraindication. Outcome measures, primary outcome which were measured were the changes in BCVA and the visual field analysis at 6 months from baseline. Improvement in BCVA was defined as a difference of 0.3 logbar or more after 6 months, and the improvement in visual field analysis was defined as a difference in mean deviation of +3 decibel or more. So results at 6-month follow-up, as we can see, the mean baseline BCVA was normal in cases as well as controls. There was no difference. However, at 6-month follow-up, it was significantly better in the cases who were given levodopa. Visual field analysis, it was improved in 5 cases in group A, while in 4 cases in the group B. This is a diagram that is showing the difference in the baseline active BCVA in cases and controls. Comparative analysis of group A versus group B was done in terms of visual acuity, and we can see there is significant difference in the patients who were given levodopa. Discussion, as there is no safe dose for ethambutol and its toxicity is reported at a dose of even as low as 12.3 milligram per kg per day. The incidence is largely dose dependent, and as per new guidelines, average dose is 20 milligram per kg in adults, while in children it is 25 milligram per kg per day, which is significantly high. The risk increases in conditions like malnutrition, advanced age, alcohol, tobacco, renal dysfunction, diabetes, and hypertension. Till date, there is no definitive cure for ethambutol-induced ocular toxicity. Therefore, early diagnosis and timely intervention is the key to its management. It should be stopped immediately with the supplementation of zinc, copper, and vitamins, especially methylcobalamin and pyridoxine. And we can add levodopa after ruling out the contraindication of any monoamine oxidase inhibitor use. The main purpose is primary prevention, and the information material should be given to patient. All patients with high risk factor must undergo baseline ophthalmic evaluation before starting. Levodopa appears to be beneficial in treatment of ethambutol-induced optic neuropathy. However, large multicentric studies should be conducted to be more conclusive regarding its efficacy. Thank you.
Thank you, Dr. Monika. What was the reason for deciding on levodopa?
Sir, as there are many articles that are published over the use of the levodopa used in non-arteritic ischemic optic neuropathy, and there is no certain cure, so we wanted to evaluate the role of levodopa.
But how does it affect the pathophysiology of ethambutol toxicity?
Sir, we have stopped ethambutol and we are already following the primary treatment. Along with that, we have added the levodopa. We haven't stopped.
I wanted to ask, what is the scientific basis of adding levodopa to?
Sir, as it has a protective role in the RNFL thickness, and there are 2-3 articles that are already in phase 3.
In ethambutol toxic neuropathy?
No, sir. Yeah, sir. The patients who were given ethambutol, OCT changes were being studied, and the cases who were given levodopa, there is less decrease in the RNFL, even after UAL.
How was it justified? Because the background of ethambutol toxicity is zinc chelation and affecting the oxidative
Sir,
cycle.
as it is partially reversible in initial stages, and we wanted to increase the neurotransmitter level in these patients, and I think there is already a trial going on in AIMS also over this study.
No, I wanted to ask the justification. Whether it's going on in AIMS is not the justification. I wanted to ask that what is the scientific justification of giving levodopa to?
Sir, as the dopamine is a neurotransmitter, and that will help in the.
Okay, sure, great.
Thank you, sir.
Just wait, I think there are a couple of more questions.
You're Dr. Monika, isn't it?
Yes.
Yeah, just to confirm. Good presentation.
Thank you, sir.
Timing for 5 minutes each talk? Each